Hello, everybody. My name is Robert Riley, and I'm an interventional cardiologist at the Christ Hospital in Cincinnati. And on behalf of the TCTMD newsletter, I'd like to welcome you guys to our latest installment of the CHIP Update series. This is a new series that we've started for the newsletter where we interview luminaries in the CHIP field that really have a special focus on various issues pertinent to the CHIP space. And today I have my good friend and colleague, Dr. Sunil Rao. Dr. Rao is a professor of medicine at Duke at the Durham VA. He's well known in our field and really represents the elusive triple threat, an amazing, phenomenal clinician, educator, and investigator. And it is truly an honor to have him with us today. So welcome, Dr. Rao.
Hey, thanks for having me, Rob. It's a real pleasure to be here. Thank you.
Absolutely. As you guys know, Dr. Rao has a long track record of extensive experience performing complex procedures and was an early adopter of the radial approach for PCI. He has published and taught extensively on this topic, among many other things. And because of his expertise in radial procedures, we wanted to bring him in specifically to speak about how radial access can be incorporated into CHIP procedures, which is the big focus of our interview today. So just starting off, Sunil, can you tell us a little bit about your practice and specifically your CHIP practice and how it's grown over the past 5 years?
Yeah, absolutely. So I have multiple roles here at Duke and then the Durham VA. I run the section of cardiology at the Durham VA. And spend most of my clinical time in the cath lab, usually 2 to 3 days a week. I think like everyone else, we've noticed that the complexity of our procedures has dramatically increased over time. And that complexity is not just the complexity that we see anatomically, but the overall clinical profile of the patients is much more complex now. Patients are getting older. They tend to have very, very high surgical risk. So we're doing probably, 2 to 3 surgical turndowns a week, and that's just me. The other operators as well are also seeing that kind of a clinical volume change. So it's interesting, I think as the data has supported more and more of an initial medical therapy approach to stable angina, we're seeing a lot more ACS patients now. And those patients, tend to have very, very complex coronary disease with all the comorbidities that they come with. And so we've just had to become more adept at doing complex procedures and trying our best to achieve a surgical revascularization type of PCI.
Yeah, so it sounds like from what I'm hearing from you, not just as somebody that sort of specializes in CHIP procedures, but really all of your colleagues seem to be seeing this generalized increase in both anatomical and physiologic complexity. So a lot of this stuff is really pertinent to us, regardless of whether we consider ourselves CHIP operators or not.
Yeah, that's right. I mean, I think eventually, I think what's going to happen in the field is that this distinction is probably going to go away and everyone's going to just have to become a CHIP operator because really, if you look at the very, very low complexity lesions, you got to sort of wonder maybe an initial trial of medical therapy is the way to go. And if that fails, then go ahead and do PCI.
Yeah, I think that's a really, really interesting caveat there. So transitioning just a little bit, you were really a very early adopter of radial coronary angiography and PCI, and have really been involved in a lot of education surrounding the adoption of radial practices. Can you tell us a little bit about particular challenges and success you've had with education and then subsequent uptake in this area?
Yeah, well, thanks again for the kind words. I mean, I was an early adopter in the U.S. I mean, obviously, radial approach dates back to 1989, where I'm embarrassed to say I was a freshman in college then. So, yeah, I guess it was relatively early for the U.S., although other operators like Ian Gilchrist, Ron Caputo, Tiff Mann were doing it. I think that it's really been enjoyable to try and generate evidence around radial access. Physicians tend to be creatures of habit, and that may be true perhaps more in procedural fields. So trying to get through these misperceptions about what you can and can't do with radial approach has been the biggest challenge, I think. And thankfully, there's just been lots of data coming out about how you can, in fact, apply radial access to the vast majority of complex PCI procedures.
Yeah, and I think that misconception about sort of what you can and can't do is really a big point for a lot of us as we continue to adopt this into our practice. Sort of on that note, what are kind of the top 2 or 3 technical advances in radial PCI you've seen in the past couple of years, and how have you sort of incorporated that into your practice to make this transition as you talked about?
Yeah, and I think that's a really important point. I mean, a lot of what we're able to apply now radial access to is largely because of developments in the device space, right? So I think the biggest advance, I think, for us in applying radial access to complex procedures is the ability to use large bore guides. And whether that's a sheathless approach with dedicated sheathless guides that are available, or with so-called slender sheaths that allow us to actually put a sheath in the artery and minimize the arteriotomy, but still use 7 French guide. That, I think, is the single biggest advance, because we no longer have a limitation with respect to the guide catheter size that we want to use for some of these very, very complex procedures where you may want to use a 7 or 8 French sheath. I think there's been significant advances in hemostatic devices as well. And probably very similar to your practice, the vast majority of our complex PCI patients are going home the same day. And really, there was no way to achieve that unless you've got a very, very safe procedure. And I think some of the devices that we have now really allow us to do that.
Absolutely. So in that line, what are some sort of tips and tricks, equipments and things that you've really found to be useful, either for your routine and or chip cases, both for radial, left radial, ulnar? How have you seen some of these other alternative non-femoral access points come into your practice?
Yeah, that's a great question. I think a lot of us have become very creative about, keeping procedures very safe. And I think the number one tool that I think we found the most helpful in our lab is ultrasound. And I mean that not just for intravascular ultrasound, which of course is essential to just intravascular imaging. I'm talking about ultrasound guided access. That has really been a game changer. And now it's interesting for us to talk about the current generation of fellows has grown up with using ultrasound in the ICUs. I was growing up in an era as a resident and fellow where you just sort of used your fingers and sort of, try to use anatomical landmarks instead of ultrasound. But ultrasound really makes a huge difference because it opens up the possibilities of vascular access. So if the radial is too small, you can look at the ulnar. If you do have to go femoral, I think ultrasound-guided femoral access can really reduce the risk of vascular complications and potentially approach a safety that's similar to what we see in radial access. So that's really the number one sort of tip and trick, if you will, is to just use ultrasound routinely for vascular access. The other trick, I think, is, or tip I can give you is that the great thing about radial approach is that it's very forgiving. So if you are going to do a complex procedure, you no longer have to balance, geez, can I get away with this using a 6 French guide? Go ahead and use a 7 French guide, whether you're putting it in through the radial or the ulnar, depending on what your ultrasound shows you. You can get away with that because the arteriotomy is small enough and superficial enough that you're really not going to suffer, the patient's not going to suffer a bleeding complication, and you'll have the advantage of having that large bore guide.
Yeah, those are some fantastic thoughts, and I really, really appreciate that. And I think so many of the excuses that we as a community have made over the years, myself included, really have mitigated by a lot of data, especially things that have come out in the past couple of years. And I think that's really pushed a lot of us to change our practices. So I really appreciate a lot of those thoughts. Transitioning just a little bit, so you've got an extensive publication record and currently serve as the editor-in-chief at Circulation Cardiovascular Interventions. Can you tell us a little bit about what you think have been the most impactful investigations in the chip space over the past couple of years?
Yeah, it's been great to see this burgeoning field, right? I mean, what I think we should be proud of in the interventional cardiology space is that, we are a group that, takes clinical observations and then tests them, whether it's through observational data or through randomization, and really comes up with the right answer. So I think over the last 5 to 10 years, there have been a series of publications that are really, really important for the chip operator. I want to call attention to 5 of them, if you don't mind. One is a paper written by Ted Bass in 2015, which is called High-Risk Percutaneous Coronary Interventions in Modern Day Clinical Practice, where he just sort of gives an overview of how you integrate complex PCI into your practice and what are the kinds of things that you need to look for and how you can actually make this an efficient practice. The second is a terrific paper by Scott Garg and Patrick Sorois in 2010 in Circ Interventions, where they talk about the clinical syntax score. This is something that I think all of us are doing sort of organically anyway, which is looking at patient characteristics as well as coronary anatomy. So this so-called clinical syntax score, taking into account age and other clinical comorbidities, really is highly predictive of outcomes and can help you plan your procedure. I think one of the things that we need to do a little bit more often, particularly for our very high-risk patients, is involve anesthesia in the cath lab. So we're not having to worry about, a sort of a calm environment and making sure the patient is comfortable during our cases. 2 other articles that I think are super important are an analysis from the BESIS registry in England by Tim Kinnaird and his colleagues, looking at the association between operator volumes and unprotected left main PCI. And similarly, a great paper from the BMC squared registry in Michigan, looking at the association between operator volume and CTO PCI success. Both of these articles come to the same conclusion, which is in order to have really good outcomes for so-called chip procedures, unprotected left main, CTOs, you got to do it a lot. It's got to be something that is part of your practice that you wake up every day thinking about and how to do it better. This really is not for someone who is just going to encounter these procedures every once in a while, because really the data support a strong operator volume outcome relationship with these complex procedures. And finally, a great paper that we just published this year in Circ Interventions, and you'll excuse me, all of these are Circ Intervention papers, as you can imagine, is a great article by Jake Dull and Bill Lombardi, looking, and yourself, actually, you're a co-author on this paper, looking at the management of PCI complications and the algorithmic approach. This is an incredibly important paper because for us in the chip space, it's not just about efficacy, it's really about safety. And we know that these patients, because of their clinical comorbidities and the complexity of their coronary anatomy, you are going to have to deal with complications, and you've got to know how to deal with that in a calm way so the patient can actually leave the cath lab in a way that you can all be satisfied with, and the patient has a good outcome.
Mm-hmm. Oh, that's fantastic. That is a fantastic review. Some really important articles I hope we can all go back and take a look at. It really boils down to how do we deliver evidence-based medicine to our patients and keep these procedures safe and efficient, and then have the knowledge of how to deal with complications when they do arise. So I really, really appreciate that. For our younger academic focused operators, specifically our chip operators, given your sort of track record, what advice would you give to people who are sort of trying to go along that track?
Yeah, I think the things that I would say, and things that I learned along the way, potentially the hard way, is that I really think that it's important to not lose your clinical focus and your clinical activity. I think in order to really have an impact in the academic field, particularly in a procedural field, you got to do procedures.
Mm-hmm.
You have to understand what the person who's in the trenches every day is going through, and really make sure that you maintain your clinical practice. The second is that I think that particularly, what we've noticed over the last 6 months with the sort of flurry of trying to, rush to publish things in the COVID space, is that it's really, really important to maintain academic integrity and the integrity of the data. So, if you're at a place where potentially you don't have colleagues that are necessarily interested in academic work, reach out. I think interventional cardiology is very collaborative. Form partnerships so that you can actually publish things that you can be proud of. And the last thing that I'll say is that it's really important for all of us as interventionalists to get involved with the professional societies. SCAI, ACC, these are organizations that are really driven by membership. And if you want to make an impact on how the field is, the direction the field is going, it's really important for all of us to get involved.
Absolutely. And those are unbelievable pearls of advice. And I think, what you brought up just about ensuring not only are we producing data for the procedures that we're doing, but ensuring its integrity and really making sure that it's without blemish as much as we can in a very sloppy field that is generating data.
Yeah.
So finally, I just want to wrap up a little bit with what are some future investigations that you see coming down the pipe and some challenges in the chip field?
Yeah, so I think, one of the challenges that we have in the chip field, as you know, is that we're constantly pushing the envelope. So it's really hard for the data to keep up. I think it's important for us to understand the role of our devices. The ECLIPSE trial, which is looking at orbital atherectomy, is a really, really important advance, I think, trying to understand the role of atherectomy and how it can fit into our clinical practice. That's going to be an important investigation. We continue to figure out, which patients we can shorten DAPT on, which ones we can't. Unfortunately, the chip patient population is sort of the classic contradiction in terms, right? We know that longer duration of DAPT is helpful in complex PCI, and at the same time, they're the same patients who have very, very high bleeding risk. So I think that kind of precision medicine is something that we're going to be seeing a little bit more of. my personal interest has been in implementation science. So, I'm really interested in taking all this data that we've generated and all these evidence-based practices and trying to figure out how we can actually get people to do it. It took the British Navy, 200 years to make sure that they had limes on all their ships. Hopefully we can shorten that time frame to implementing evidence-based practice.
Absolutely. Well, that was fantastic. Thank you so much for spending time with us today and enlightening us with your experience, Sunil. And on behalf of the TCTMD CHIP newsletter, thank you all for joining us, and we look forward to bringing you new content again next month.
Thanks very much, Rob.